Respiratory. Let's hear those sounds. Let's hear those sounds. I hear those sounds. I hear those sounds. Here's those sounds. What do you hear? They may not be that obvious to you, this sound, but what is it? It is a sound that sounds like bronchial breath sounds. What does that mean, bronchial breath sounds? Well, the most accurate test of anything in the chest is a chest x-ray, chest CT, chest x-ray, and chest CT. And the most accurate test is chest x-ray and chest CT. And anything that we're going to ask about in the chest that has a sound is probably going to end up being pneumonia, right? So bronchial breath sounds, also known as tubular sounds, are high-pitched sounds that's heard over the sternum, and they have some clear inspiratory and expiratory components because they're caused by consolidation. They're the increased transmission of sound that's through the bronchial tree, and it sounds like fluid going through a tube. So let's have a little agreement here. No matter what it sounds like to you, you're going to agree with our definition. The textbook definition of what a bronchial breath sound or tubular sound is. It's going through the bronchus, which is acting as a tube. The bronchus is a tube, and it's surrounded by consolidation. And the chest x-ray and the chest CT, welcome to being a pulmonologist. It's going, yeah. Now, chest wall percussion, we don't do too much chest wall percussion anymore. But chest wall percussion is a way of looking for consolidation. You just tap, 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 tap. Man, I can't remember the last time somebody was tapping chests. Tapping chests is a leftover, really. Now, the respiratory section is going to have a lot of things that when you get onto the floors as a third-year student, you're not going to see people doing. But just because you don't see them doing it doesn't mean that you're not supposed to be trying. So bronchial breath sounds, yes, you're doing auscultation. You're not just walking in and saying, I'll have a chest x-ray and a chest CT. And chest wall percussion. Dullness to percussion means consolidation. That's what chest wall percussion means when it's abnormal. First, okay, it means consolidation. Hyperresonance is like emphysema. So the most accurate test on to confirming the diagnosis is imaging of the chest. So here's chest wall percussion. Yes, I'll feel it tapping. Then gently there came a tapping at my chest wall door. Quote my doctor, nevermore. Tapping on the chest wall with the hands and the fingers and giving them the middle finger. You know, anyway, let's tap on the chest wall with that middle finger and striking it there so that you can see whether there's density or not. Dullness to percussion is consolidation. Consolidation with gooey stuff like pneumonia. Consolidation like an effusion. Consolidation like squished lung with atelectasis. Consolidation like infection, mucus, fluid, goo, liquid in the chest. Dull. And hyperresonance is a pneumothorax, COPD, emphysema. In other words, less dense lungs. Sounds more like a drum. Less density sounds more like a drum. Pneumothorax and emphysema sounds more like a drum, man. And that's hyperresonance. Well, we're in the pulmonary section. We're in the respiratory section. So give me a time not to say chest x-ray or chest CT, because we are, after all, in the pulmonary section. So chest wall tenderness, that's not quite percussion. You see, chest wall tenderness is just pressing and pressing. Ooh, you know, there's not that many things that cause actual wall tenderness. Does pneumonia cause chest wall tenderness when you press on it? No. You see, this is a big difference. You see, dullness to percussion, effusion, pneumonia, consolidation. But actual tenderness of the wall where the ribs hurt, ooh, not too many things do that. Not too many things do that. Chest wall tenderness can be bone abnormalities. Chest wall tenderness is from inflammation. So anytime you see inflammation, you should say anti-inflammatories, like non-steroidals, like anti-inflammatories from non-steroidals. Chest wall tenderness, you're pressing on the ribs, so it must be rib tenderness, like costochondritis. Rib tenderness, Remember, chest wall tenderness is much more important for the things that don't have tenderness. In other words, tenderness actually is good. It means you don't have a lot of serious things like going to die of a myocardial infarction, like pneumonia. And it's just inflammation of the joint, the chest joint. See, the reason that you don't think about it is that you don't know how much your rib cage moves when you breathe. You haven't quite realized that, like, but why don't you tighten down your chest and try and breathe without your chest wall moving? Wow. You'd really see that chest wall tenderness is a rib problem, and you don't realize how much your ribs move every time you breathe. Non-steroidals are anti-inflammatory of the chest wall and help you to overcome the inflammation of those ribs. Occasionally, rarely, almost never, you give them a shot of steroids because it's inflammation. Now, Cheyne-Stokes respirations. Well, Cheyne-Stokes respirations, what do they mean? What does it mean? Cheyne-Stoking is a pattern of cyclic respirations where you breathe fast and then you don't breathe at all. Looks like you're about to die. You know why it looks like you're about to die with Cheyne-Stokes? It looks like you're about to die because you're about to die. Cheyne-Stokes is a nearly terminal respiratory breathing pattern. You breathe fast, then you stop breathing, and then you look like a fish that's just been thrown on the shore. So it's oh, it's terrible to watch this. Looks like people suffocating. Do you know why it looks like somebody is suffocating? Because they're suffocating. It's terrible. That's Cheyne-Stokes respirations. And basically what's ending up happening is your medulla is in the process of dying. And you get to the point where it's like the safety on your breathing. Like, why can't you just hold your breath to commit suicide? Because CO2 would accumulate and force you to start breathing again. So when Cheyne-Stokes respirations are in the question, it means severe injury to the brain. There's a stroke, there's hypoxia, meningitis, infection. I mean, you just can go through and name all the things that basically mean I've just destroyed your brain. And the brain stem is holding on by its fingernails. So, like, for instance, barbiturates can kill you from respiratory toxicity. So do opiates. Opiates kill you from shutting off respirations. Alcohol, seizures, and shutting off respirations. So these intoxications will kill you by damaging your brainstem to the point where you have interfered with the respiratory centers and you're about to die. And that's how these toxicities work. And so it means that you essentially, you're dead. You stop breathing, but your body like picks up the toxicity of the CO2 at the end and sort of like sends you in some emergency breathing at the end. But it's not pretty. You look like you're suffocating. You're intermittently dying, but your heart beats okay. And this breathing precedes death. If you've been around as many people dying, that's what you're going to be a doctor for. So, this is a finding. Why is it that you get clubbing when you have chronic respiratory illness? What makes you get clubbing? I know you get hypoxic, but why does hypoxia make your fingers big? Are you going to breathe through your fingertips? Why does hypoxia, why does chronic lung disease make it so that you are clubbing? And the short answer is, we don't know. But we do know that chronic hypoxia from lung disease, makes your fingertips big. Chronic hypoxia from lung disease makes your fingertips big. The mechanism of why the fingertips is not clear. Because if I say, why does that happen? People go, well, hypoxia. Yeah, but why hypoxia? Why doesn't your ass get big? Why does your penis get larger? Okay, why is it that you have to have it, that your fingertips get big? So you just have to say, I don't know, and then maybe we'll find out someday. Mostly, you know why we don't know? Because it doesn't matter that much. It doesn't matter that much. We haven't figured out why the tips of the fingers, and all we can tell you is that all you can do is correct the hypoxia, and that's it. Clubbing. What do you see? Stop. What's that sound? It is crackles or crepitations. For those of you who have hair, take your hair and rub it in between your fingers so that you can listen to what hair sounds like, or hear. Anyway, take your hair and crackle it up in between your fingers. Yeah, so crackles or crepitations. They're the sound of lung disease, and they're the sounds of alveoli popping open like popcorn. So the diseases associated with crackles is pneumonia. So they sound like hair. Rub your hair. Come on. In between your fingers. And it's heard during inspiration. Remember, wheezing is heard during expiration. Wheezing is expiratory sounds like a flute. Wheezing is an expiratory sound. This is like air bubbles popping open as the lungs fill up with air and they open with a pop, 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 pop. Crackles are caused by the sound of alveoli opening. And remember, the smaller it is, the harder it is to open. As it gets larger, they pop open more because there's our friend, the law of Laplace. Now, excessive airway secretions makes it so that you have more pressure on the alveoli, so the popping is greater. That's why consolidations of infections end up causing these crackles and crepitations and popping, because it is a sign of fluid in those lungs, pulmonary edema, and especially pneumonia. Anything that makes the lungs denser, it goes pop, like exploding popcorn. Next one. What's that sound? So this one is egophony. Ooh, egophony, bronchophony. Great names, right? Well, egophony and bronchophony are sounds that were more important when you didn't have an X-ray and a CT machine on every street corner. When you had to examine people and say, do you have consolidation? These are signs of consolidation. They are things where you go, E, and it sounds like A, and then say E, and it sounds like A, E, A, A, E, A, E, E, A. Yeah. So E to A changes, and they're sounds of consolidation. And also, which transmits sound more? Air-filled lungs or fluid-filled lungs? Which is going to transmit sound more? It's actually a fluid or dense lung transmits sounds more. So normally, if you're listening to somebody's chest and they're speaking and they're going, hola, that means hello. Okay, you shouldn't hear it. So but if you hear it and you put a scope in there and you go, hola, that means hello, and you can hear all of that, that means that you've got an increased density of lungs that's abnormal. You should not be able to hear things that much in a normal air-filled lung. It is the respiratory section. So egophony and bronchophony are diagnosed with chest X-ray and chest CT. Bronchophony says normally spoken words are soft and indistinct, except when the lung is condensed and solid and it transmits more. It sounds louder because there's a greater force of vibration that can pass through solid material. And egophony is when you ask somebody to say, E, and it sounds like A, E, A, E, A, egophony. We should call it egophony, don't you think? If it was called egophony, then it would sound like E to A changes. And again, these are signs of consolidation, pneumonia, effusions. The consolidation have an increased density, and the greater the density of lung, the more solid, the more it transmits sound compared to air. Air doesn't transmit the sound as well inside a lung. It just doesn't. Dampens the sound. But that's why these are just two different ways of saying increased sound, so it sounds louder, and E to A changes. Chest X-ray, chest CT. Our next respiratory slide, here we go. Kussmaul breathing, physical finding. What changed Stokes was you stop, that's like zombie breathing. And Kussmaul is getting laid in the backseat of a car breathing. Fast, deep breathing, defined as rapid, deep breathing, faster. Gonna breathe myself now, faster. Having acidosis, faster. And I'm breathing respiratory compensation. DKA, lactic acid, methanol and ethanol, and ethylene and glycol. Rapid deep breathing, Kussmaul. And Kussmaul's breathing is regular deep inspiration with a tidal volume and alveolar ventilation are up. Now remember that you're going to see this later on when we do physiology more, is that increased rapid deep tidal volume means more alveolar ventilation, and alveolar ventilation is the one we really like because that's the one that really exchanges gas. That's the alveolar ventilation is the one we really like because it's the one that really exchanges gas. So alveolar ventilation is the bueno because we want the ones, there should be no alveolar ventilation. Alveolar ventilation should be where everything really hits in alveolar ventilation. Now it can be fast or slow. Most of the time it's fast, but it's regular deep breathing and usually is part of respiratory compensation. But the minute ventilation goes up, you see respiratory has all these words for it that's unique to it. Alveolar ventilation is where the gas really exchanges. Minute ventilation is like saying cardiac output for the lungs. Respiratory rate times alveolar respiratory rate times tidal volume. Respiratory rate times tidal volume. Minute ventilation. Alveolar ventilation is the part really gets down there to the respiratory zone. And it's usually compensation for an acidosis of any kind. Meaning you can't tell when somebody has Kussmaul's. Is it diabetic ketoacidosis? Is it lactic acidosis? Is it methanol? Is it aspirin? Is it uremia? You can't tell. You're just breathing deep as a part of acid stimulating the brainstem. Remember, what are those three stimulants to breathing? Acid, carbon dioxide, hypoxia. Acid, carbon dioxide, hypoxia. Which of those is the weakest? The weakest is hypoxia. Because hypoxia doesn't really kick in until you get peripheral chemoreceptors. And peripheral chemoreceptors, remember physiology, okay? Peripheral chemoreceptors don't kick in until the PO2 goes less than 60. So the peripheral chemoreceptors are in the carotid, the aorta, the carotid, the aorta, the carotid, the aorta, less than 60. But acid, and especially carbon dioxide, central chemoreceptors, brainstem. And central chemoreceptors in the brainstem are much stronger. You can't overcome them very well. Now, it's a direct effect that Kussmaul's breathing of salicylates, because salicylates cause both metabolic acidosis, which we're going to compensate for, and they directly stimulate the brainstem and make you breathe faster. So the moral of that is, treat the underlying cause. In this case, alkalize the urine for excretion. Alkalize the urine for excretion. Isn't it exciting?